Hello, and welcome to this webinar titled Introduction to Promoting Interoperability for the Merit-Based Incentive Payment System in 2019. My name is Brett Papke. I'm the Director of Eye Care Professional Services. I have the honor and pleasure of walking you through this discussion today. It's really an introduction to some new ideas that will be present in the 2015 edition of RevolutionEHR that you'll see here coming in the first quarter of 2019. Now, in our objectives for this discussion, we want to review the Merit-Based Incentive Payment System scoring system. We want to introduce the Promoting Interoperability Performance category of MIPS, define each measure within that category and illustrate how it's tracked by RevolutionEHR, and discuss the point reallocations that take place in the case of an exclusion. Now, I realize that may seem a little bit complicated just in text, but I promise we'll try to make sense of it as we go. Now, first, remember that the merit-based incentive payment system replaces the individual requirements of programs like meaningful use, PQRS, and the value-based payment modifier. It keeps some of those concepts in place, but offers revised versions of those programs that become components, or otherwise known as performance categories of the merit-based incentive payment system. And you can see those categories over here to the right. Now, the percentages within those categories represent the weighting that these categories have on a provider's final score, because ultimately that's what MIPS does. How you do within these four categories determines what MIPS final score you are assigned. 25% of that score is coming from this category that we're talking about in this webinar, Promoting Interoperability. But anyway, your final score gets compared to a value known as the performance threshold. And in the not too distant future, that performance threshold is going to be set at the average of all providers that are participating in the merit-based incentive payment system. But regardless of how it's determined, your final score gets compared to the threshold, and if your score happens to be higher, you're going to see your Medicare Part B reimbursements going up 2 years later. If your final score happens to be lower, then you're going to see your Part B reimbursements going down 2 years later. And the farther away you are from that performance threshold, whether above or below, the more significant the upward and downward revision would be. Now, a performance year is always influencing your reimbursements 2 years later. So when we're talking about participation in 2019, like we're doing here, we're talking about influencing your reimbursements in 2021, and you'll be doing that on the order of plus or minus 7%. Now, at the bottom here, a very important point is that not all optometrists are required to submit data. That's been a big point of contention within the merit-based incentive payment system for the first 2 years of the program. 2019 now offers a path to opt into participation to those who may not be eligible or considered eligible through traditional means. We covered eligibility, that entire opt-in process, in an early webinar titled MIPS 2019, What You Need to Know. You can find that in recorded fashion on the Revu website. Now, many may be familiar with the idea of certification, or at least have heard the term before, but may not know exactly what it's all about. So when you hear the term certification, think about the idea that it's a virtual proving grounds or testing process that EHR vendors need to go through to demonstrate certain core capabilities centered around the sharing of data. It really levels the playing field between EHRs by getting them speaking the same language, or at least ensuring that they have the same core capabilities of making it easier for providers to share data with one another. Now, quite often, the term certification is confused with the idea of quality reporting programs, and that is to say that people may think that a certification process is undertaken simply for the benefit of quality reporting program participation, and that's not the case. But since quality reporting program participation, such as we're talking about here in the Promoting Interoperability category of MIPS, since both certification and promoting interoperability are aligned in focusing their efforts on making it easier for providers to share data with each other, their patients, and their patient families, CMS makes it an absolute requirement of you to be using a certified EHR in your participation. So that's one of the fundamental ideas of 2019, is you need to be using certified software during your promoting interoperability performance period. So if we talk a little bit more about what certification is and what we did, RevolutionEHR actually added or enhanced capabilities across 40 different criteria in the 2015 edition software that you'll see shortly. Some examples include enhancements to direct messaging. Clinical information incorporation and reconciliation will be demonstrating that process in this discussion today. Really involves putting you in a position to receive a document from another provider and electronically drop that information in the patient record in RevolutionEHR. Enhancing some abilities around sending and receiving transition of care documents. For example, when you receive a file from another provider and you view that in a human readable format, you now have the ability to customize that. So if you didn't want to see certain fields by default, say for example immunizations don't mean anything to you, you could have those hidden so you're only seeing the important information or the information that you consider critical to your care of the patient. Enhanced PHR capabilities for patients. Patients will now be able to filter their information based on date. They'll be able to transmit information through different mechanisms to other providers. And then right below that, API access for third parties. API stands for Application Programming Interface. RevolutionEHR needed to build an application programming interface to allow third-party vendors to build applications that a patient may have on a mobile device, with the thinking that a patient who sees maybe 4 or 5 different providers doesn't want to log into 4 or 5 different PHRs to see their information. So these applications would serve as aggregation tools that would pull data from all 4 or 5 of those different providers and display them on the patient's mobile device. The benefit there being, of course, the easier it is for a patient to get access to data, the more engaged in their care they become, and the more engaged in care that they are, we know the better the patient outcomes. And then finally, of course, there'll be improvements in the clinical quality and MIPS measure tracking scorecards within the software. Now, it is our plan to release our 2015 edition of RevolutionEHR, which will be dubbed version 7, in February of this year. That gives us time between now and then to talk about what needs to be done to be successful in the promoting interoperability category. And that's really one of the foundations or reasons why we're doing this or publishing this discussion here. If anything that we say throughout the discussion doesn't make any sense, of course, we have lots of different ways for you to get in touch with us, whether that's the Quest for Excellence community on Facebook, quality reporting at rev-360.com is an email address that you can use, or if you happen to be within the application, feel free to use the Ask About MU and MIPS link right within the Help menu in Revolution. But understand, as we bolded in red here at the bottom, that your promoting interoperability performance period in 2019 absolutely requires you to use 2015 edition software. So what that means to you is that you right now are not participating in promoting interoperability for 2019. So don't consider that to be your official participation, don't consider you to be participating in that category right now. You can certainly be participating from a practice standpoint, but you can't officially be entering a performance period until you have that software in your hands. Again, the point or the goal between now and then is to talk about the differences in workflows that will be required for success. We're starting that process with this discussion here, and we'll talk much more about it through different mechanisms moving forward. But again, the intent is to deliver that to you in Q1 of 2019, and that'll leave you plenty of time to be successful in your 90-day promoting interoperability performance period this year. So let's talk about promoting interoperability. As we said before, it's going to account for 25% of your score. As RevolutionEHR customers, or said differently, as someone using an EHR, you're fully entitled to these 25 points, or at least to achieve some of them. So we want to talk about how you make that happen. Incidentally, it is possible for a provider to participate in MIPS without an EHR, but they would be leaving this 25% slice of the pie off of their score, meaning the best they could possibly do for a MIPS final score would be 75, and that's if they got 100% on everything else. So summarize all that long-winded story into a short sentence, you're in a really good position by using an EHR to maximize your score. Now, if we talk about the background here, really the only constant within promoting interoperability over time has been change. You know, it's even gone through a number of name changes. It was first called meaningful use, and then it was called advancing care information. Now it's called promoting interoperability. And if we go back to 2014, you may remember, those of you who have participated that long, you remember that's when stage 2 came about, and there were 20 different objectives and measures we needed to pay attention to. Providers complained that was a little bit too much to worry about and track. So Medicare came back the following year by introducing modified stage 2, which cut the number of requirements in half. But the big complaint at that point was that the requirements were still all or nothing, meaning you had to pass every statistical threshold that there was. And If you failed to surpass just one of those, despite doing exceptionally well on all the others, you ended up failing the program and being penalized 2 years later, just like someone who didn't even make an attempt to participate. So heading into the merit-based incentive payment system, Medicare knew that they wanted to be a little bit more flexible with things, and that's exactly what they did with the creation of advancing care information, where there were a certain number of objectives that were put in place, and it was left up to the provider to decide which of those made the most sense to their practice. However, it became exceptionally challenging to providers to understand how they were being evaluated. So in 2019, we're seeing things simplified once again to just focus on those things that promote the ability of providers to talk to one another, share data with one another, to share data with their patients and their patient families. And if we look at what's on tap here, you'll see that there's only 4 objectives: e-prescribing, health information exchange, provider-to-patient exchange, and public health and clinical data exchange. That is it. Now, there are 6 measures associated to those that we'll get to in just a second, but it's just these 4 objectives. You aren't going to see things like secure messaging anymore that measured you on your the number of messages you sent to unique patients. You won't see patient-specific education. You won't see view, download, or transmit, which, as you remember, graded you based on patients taking specific actions, which many felt were unfair for the longest time. So those have all been removed, and these are the 4 that we have left. Now, in the second column, you'll see the name of the measure. So if we look at the e-prescribing objective, the name of the measure is e-prescribing, and it's very straightforward, right? Of the number of prescriptions that you write, how many were sent electronically to a pharmacy? Beneath that, there are 2 bonus options: query of prescription drug monitoring program and verify opioid treatment agreement. Those are related to the prescription of Schedule II narcotics. We'll talk about that in just a second. Health information exchange. There are 2 measures of health information exchange. The first is support electronic referral loops by sending health information. This requires us, in the case of initiating an outbound referral, requires us to create an electronic transition of care document that we provide to the consulting physician. And the thinking is that that document is going to prepare that doctor for care of our patient by providing them with important information about our patient's medications, problem list, and medication allergies. Now, the second measure is almost the opposite of that. If you are receiving an inbound referral or you're seeing a patient that you've never seen before, it's expected that you will receive or obtain a summary of care document in electronic fashion, and that you will build that information into RevolutionEHR, or the patient's record in your system. We'll talk about the workflows involved in that in this discussion. The next objective, provider-to-patient exchange. The measure here is provide patient electronic access to their health information. This one is nearly identical to the current, or excuse me, the 2018 measure of provide patient access, where it was expected that you provide Revolution PHR credentials to your patients within 4 business days. There's another little wrinkle on this that I mentioned in the certification discussion, where RevolutionEHR needs to provide you with an API that would be available to external developers to allow patients to access their information that way. We've already done that. Okay, that API is available. So really, your only part of this requirement that you need to pay attention to is continuing to make sure that your patients are receiving PHR credentials and you're signing your encounters in a timely fashion. Finally, down at the bottom, public health clinical data exchange, there's an expectation that we do something called actively engage with 2 of these types of registries. Over to the right, you see the number of points that each of these are with. So for example, e-prescribing, if you scored 90% in RevolutionEHR for e-prescribing, you would receive 90% of those 10 points, or 9. The scoring system wouldn't aim to have fractional amounts here, so if you scored, say, 95%, you wouldn't receive 9.5 points, it would round you up to 10. So if you look at an example here and look at how the scoring works out, as I said, how you do in RevolutionEHR automatically determines the number of those points that you receive, and then the system simply adds all the points you received up to arrive at your total. In this case, the provider receives 70 total points out of a maximum of 100. So as a result, the provider would receive 70% of the 25 points available in the category, which comes out to 17.5. Now, I don't expect that scoring to be crystal clear, but those are the principles that are involved, and I hope it at least helps in understanding how the system will be evaluating us moving forward. So if we talk about what the requirements here are here, all measures are required. That is to say, you cannot simply say, this one doesn't pertain to me, I'm not going to do it. You need to report a numerator of at least 1 or a yes, or qualify for an exclusion where available. You'll note that there was no mention of an SRA in terms of how it may contribute to points, and that's because the security risk analysis doesn't contribute to points, but it is still a fundamental requirement of participation here. You need to do a security risk analysis during 2019, or you will receive a 0 in the Promoting Interoperability performance category, and you have that factored into your overall MIPS final score. Now, I've alluded to the idea that there are exclusions available. For e-prescribing, if you wrote less than 100 prescriptions, you'd be eligible to exclude. For the send measure of health information exchange, if you initiate fewer than 100 referrals during your performance period, you'd be able to exclude. On the receive side of that, if your total of new patients plus inbound referrals was less than 100, you'd be able to exclude. And then there would be exclusion possibilities for each of the public health clinical data exchange registry options. Now, interestingly, the exclusions, if we talk about them a little bit, the exclusions don't automatically assign the points to you. So for example, if I determined that if I wrote less than 100 prescriptions and I wasn't able to achieve success, or I didn't feel that I could invest in an e-prescribing system, I have the ability to exclude, but me excluding from that does not give me the 10 points for that measure. Instead, we'd see the points assigned to that measure shifted elsewhere. And I want to go through what those possibilities are, just so we sort of understand some of the logic behind that, if we can use the term logic. So let's do one with e-prescribing. We'll say in this case the provider did not write any electronic prescriptions. They were not using an e-prescribing system. So in that case, the 10 points that would normally be assigned to e-prescribing get divvied up evenly between the two measures of health information exchange. And you can see that those two measures would move from 20 points to 25 points apiece. I'm going to skip the first measure of health information exchange for a second, and let's talk about the second. If the provider was not capable of receiving an electronic transition of care document and incorporating that into the patient's medical record during the performance period, and remember the requirement is I would just need to do that one time to satisfy the base requirement here, then the 20 points that would normally be assigned to the measure would get reassigned to the first measure, making it worth 40. So you can see here that the 40-point weighting of health information exchange is not too easy to avoid. Or said differently, you can't avoid it. Medicare is putting significant emphasis on the importance of health information exchange, making it worth 40% of your score, with the opportunity for it to grow, as you'll see here in just a second. Public health and clinical data exchange. As I mentioned, there are exclusion possibilities for each of these registry reporting options, 3 to be exact, 3 for each of these. The requirement here would be that we actively engage with 2. But if we felt that we couldn't actively engage with any of these and we qualified for exclusions from them all, then we'd be entitled to an exclusion from the total objective there. And as a result, the 10 points that are normally assigned to it would move back to provider to patient exchange, moving that from 40 points to 50. So you can see the reweighting that's in place there. Now, let's move back to support electronic referral loops by sending health information for a second. And the reason I skipped it before, because it doesn't follow the logic of the others, and that is to say that it doesn't reallocate points anywhere. In fact, Medicare has officially recognized in the rule that it doesn't make a whole lot of sense what they've put as part of the final rule, and that is if you exclude from the sending aspect of health information exchange, the points simply disappear. So let's look at a potentially complicated example to see how it could negatively influence a provider's score. Here's an example where we're going to claim exclusions from 2 measures, e-prescribing and support electronic referral loops by receiving and incorporate health information. So we'll look at how the points shift around here first. So if we look at just e-prescribing first, remember we said that those points get divvied up equally between the 2 measures of health information exchange. All right, so e-prescribing is now worth 0, and the 2 measures of health information exchange are now worth 25 apiece. Next, we will exclude from the second measure of health information exchange, which would take those 25 points and add them back to support electronic referral loops by sending health information. Okay, so now we have that worth 50 points instead of the original 20. Well, what if the provider was not capable of sending at least one electronic transition of care document in the case of an outbound referral? Okay, those points don't get moved elsewhere, meaning those first three measures that we're looking at here would all be worth 0 points, which would ultimately mean that 50% of a clinician's score is missing. Now, why do I bring this up? Because I think it's important that we always keep in the back of our mind that exclusions are available for when success is not possible. I think it makes sense to keep those exclusions in the back of our minds as a possibility, but we are not required to use those if we can be successful for a measure. And being successful is how you get points for certain things. So for example, if my e-prescribing measure was, say, 5 for 5, I only wrote 5 prescriptions during my 90-day performance period. Simply being below 100 does not mean that I need to claim the exclusion. In fact, me attesting to success with 5 out of 5 would mean that I performed at 100% and it would give me the maximum score for that measure. So again, bottom line, always attest success when possible. Now, here's a slide that just summarizes the scoring impact of the different exclusions, and I don't think we need to spend a ton of time here, but I'll use it to reinforce the idea that an exclusion is not a requirement. Those 100 figures that you were looking at in terms of e-prescribing and health information exchange, those are not thresholds that need to be passed prior to attesting to success. So our guidance would always be to consider attesting to success whenever possible, yet keep the exclusions in the back of your mind as a possibility when success is not possible. All right, so those are the measures and objectives. We want to go through each of these in discussion to talk about what the requirements are and how they're achieved in RevolutionEHR. We'll start that process with protect patient health information. This is the SRA one that we talked about being a fundamental requirement of participation. And ultimately, what you're asked to do here is perform a security risk analysis of the data that you create, maintain, transmit within the walls of your practice. So not only the data within the EHR, but also looking at other instruments that you may have in the practice. For example, do you have a visual field perimeter in the office? I would assume you do. I would also assume that there's probably patient information that resides on a database on that instrument. How is that data protected? Is that data at risk? Those are the sorts of things that need to be analyzed through this process. The maximum point value here is listed at not applicable because it is not part of your score and there's no exclusions possible. Remember, we said you absolutely need to do this or you'll receive a 0 in the entire Promoting Interoperability performance category. Now, I put some official quotes here about what an SRA is, primarily because I want to call out the second bullet there that says, at a minimum, a MIPS eligible clinician should be able to show a plan for correcting or mitigating deficiencies and that steps are being taken to implement that plan. So if we put that into plain English, you need to do an SRA. That SRA is supposed to identify risks to patient data in your practice. And then from there, what you should be creating is a plan to reduce those risks. Perhaps your plan prioritizes based on risk, those different risks. I just used the word risk twice, so I apologize for that. Basically, let's say if I identified 10 different risks, I could rank those risks based on their potential impact to patient data in the practice, and then I could assign due dates to each of those risks for when I want them mitigated. And basically those two documents, the SRA and your mitigation plan, would be what would be expected of you in the event of an audit. So that documentation is really important. Now, a full or complete SRA effort will be required in 2019. Those of you who are familiar with this process, you know that we typically refer to two flavors of SRAs. There's a full or complete, and then there's a review. And typically what many businesses do is they'll initiate their security process with a complete SRA 1 year, and then in subsequent years, they end up doing a review. And maybe they'll do a complete effort again every 4 or 5 years. But the reason for that is if I was to repeat a complete effort in year 2, I may end up re-identifying the same risks that haven't been fully mitigated yet based on my mitigation plan. Now, Medicare requires that a provider perform a complete effort when they switch EHRs or they move to a newly certified version or a new edition of certified EHR technology. As we mentioned before, all of you will be moving to a newly certified version of RevolutionEHR in 2019, which means that a complete effort will be required this year. That SRA must be completed within the 2019 calendar year. It does not need to be completed during your Promoting Interoperability performance period. So if you chose, say, the third quarter of the year to be your Promoting Interoperability performance period, that does not mean you couldn't complete your SRA now or even in the fourth quarter of the year. It just needs to be done no later than December 31st of this year. Traditionally, we've seen the failure to perform the SRA and have that adequately documented as the #1 reason for audit failures. It's really easy to click a button during the attestation process and say, I did this, but it's a whole lot harder to produce documentation that never existed in the first place in the case of an audit. And that's unfortunately what we've seen a number of people encounter. Now, there's no requirement that you partner with anybody else. You could fully complete these activities within the walls of your practice without any outside assistance. Many like to partner with a third party just to have a voice of reason in the process and to bounce questions off. But understand that either route that you go is not a full outsourcing of that effort. You're going to need to do some things to understand the process and be involved in it. Now, if you do choose to keep the activity in-house, what we recommend that you consider is the ONC's SRA tool. That is a tool that you can install on an iPad or a computer, and it'll walk you through a series of questions to help you analyze your practice for risks. And it even provides documentation and risk prioritization now to help you create the required documentation. So if you partner with a third party, absolutely great. If you don't partner with a third party, you're going to try to do these things in the practice, take a serious look at the ONC's SRA tool. There's a link available on the MIPS Resource Center on Insight, and the reason we like it is because it's produced by the body that would be considered a highly reputable source in this area, and it'd be very hard for an auditor to say, no, that's not a good process that you did. All right, so let's move on to electronic prescribing. And again, pretty easy to understand this one. It's the number of prescriptions that you write that are both queried for a drug formulary and then transmitted electronically using certified EHR technology. Now, that drug formulary query part that we're talking about, or that's on the screen here, is something that's achieved by most, if not all, certified e-prescribing systems. So that's not a new wrinkle. That's something that's been in there since the beginning. The maximum point value here is 10 points. There is an exclusion available, as we said before, for any clinician who writes fewer than 100 prescriptions. And if you happen to exclude, remember we said that those 5 points get allocated to each measure of health information exchange. Now, if we take a look at some quick facts here, many of you know that RxNT is RevolutionEHR's integrated e-prescribing solution. What does integrated mean? Well, there's a Launch RxNT button in the medications module that would take you right to RxNT's e-prescribing interface. It would transfer patient demographic information over there, and then when the prescription is written and transmitted, that information flows back to RevolutionEHR. Other certified e-prescribing systems are absolutely fine to use, but remember that the MIPS PI scorecard is only going to be able to track actions from the integrated solution of RxNT. That's not to say you can't use that outside system. It just means you're going to need to be able to manually track or produce a report at the end of the year that's going to give you the data that you need to submit to Medicare. If you're using a certified e-prescribing system and you write the vast majority of your prescriptions that way, you're going to do very well on the measure, regardless of your prescribing volume. And this bullet's really to reinforce the point that we said before about exclusions and the fact that 100 is not a threshold that needs to be surpassed before you can attest to success. If you write less than 100 prescriptions and all of them are done electronically, you can absolutely attest to success here versus claiming the exclusion. And I didn't mean to make it sound like you need to be at 100% there. Remember, the requirement is you only need to send one prescription electronically to avoid the exclusion, but obviously the more of the prescriptions that you write that are sent electronically, the better your scoring is going to be. Now, I mentioned that there were 2 bonus options available, one being related to the prescription drug monitoring program and one being related to opioid agreements. Those probably will not apply to the bulk of optometrists, and I'll claim a little bit of ignorance here because I'm not familiar with the different prescribing capabilities of optometrists across all the different states. I guess that's one of the complications of not having our abilities cross state lines. But many of you know that the schedules of medications range, of controlled substances range from Schedule 1 down to Schedule 5, and they're ranked based on the potential for abuse. Schedule 1 would have the highest potential for abuse, Schedule 5 would have the lowest. And when we look at what's on Schedule 2, you're looking at things like methadone, oxycodone, things in those families. Something that I know some optometrists prescribe, Tylenol with codeine, that's not a Schedule 2 narcotic. That's actually a Schedule 3 controlled substance. So again, I'm not sure how many people would be in position to qualify for these bonuses, but the point would be, if you prescribed a Schedule 2 narcotic and you queried the prescription drug monitoring program as part of that prescribing process, then you'd be entitled to the 5 points for that bonus measure. The capabilities or the functionality to achieve that will be achieved most likely through your e-prescribing system. I can speak from the standpoint of knowing what RxNT has planned, and they're going to have an integration on their side where there will be another tab in the e-prescribing interface where you'll be able to perform that query. So again, know that those are bonus options. They are absolutely not requirements, and those bonus options actually are changing in the future as well. We won't see one of those in the 2020 performance period. All right, let's move on to health information exchange. Remember, we said there are 2 measures here. The first is support electronic referral loops by sending health information. And if we put this into plain English, we said that anytime we initiate an outbound referral, there's an expectation that we will create an electronic transition of care document or summary of care document, and then we're going to securely transmit that to the provider with whom we are requesting the consult. That document's going to have important information about the patient, like their medication list, medication allergies, their problem list, and the belief is that that's going to prepare that other provider to better care for the patient. The maximum point value here is 20 points. There is an exclusion available for providers who were not capable of achieving that 1 in the numerator when they referred fewer than 100 patients out during the performance period. And in the case of an exclusion, remember that those points are simply going to disappear. Medicare will probably issue an update on that later in the year, but as of right now, they simply disappear. So we want to be successful here whenever possible. So let's take a look at RevolutionEHR to see what the workflow involved is. We'll see here that I'm on a patient dashboard, and if I scroll down and I'm looking at the left margin, I'll see that there's a component here known as referrals. If I select the referrals component, I'm taken to a historical overview where I'd first see all the historical outbound referrals that I've initiated for the patient. You can imagine how that could be helpful in getting a quick view at the care that you may have coordinated for this patient. But if I use the plus button over to the right, that's going to start a new referral for me. And you'll see there's 4 required fields over here on the outbound aspect of the referral. The referral date and the referred by sections are automatically populated for me. But what I need to fill in is who I'd like to refer the patient to and why. So in this case, let's say I'm going to send the patient to Dr. House for surgical evaluation of cataracts. From there, there's remaining sections that I could use if I'd like to. I don't have to. It doesn't impact this measure at all. But you'll see that once I add this referral, the transition of care documents buttons become available here. One says send, one says generate. Now the difference between those two is that generate creates a non-electronic version of the document. And that can certainly be helpful in cases where the consulting provider may be on paper or isn't comfortable with the electronic sharing process. But for the purposes of this measure, the only thing that's going to count for you is use of that send button. And that send button only becomes active when both the sender and the receiving provider both have direct addresses logged in their profiles in RevolutionEHR. Obviously, the referred by, that designation or that indication of the direct address would be within their employee profile, but the referred to would be to an external provider, and that designation would be available through admin, vendors, partners, external providers. So if I was to go through the workflow here associated with the measure, when I initiate my secure message to that consulting provider, we'll see that in the attachment section, my summary of care document is automatically going to be attached for me. Now, I can browse my workstation and attach any other files that I'd like. For example, if I have fundus photos or previous OCT or visual field or whatever it may be, if I wanted to attach something else to this message, I certainly have that capability. I could also type a brief message to Dr. House here to let him know any of my thoughts about the case. When I select send, though, the system processes that message sends it just like any other email, but it's going to be in a secure fashion through the direct protocol. That's going to ultimately arrive at Dr. House's practice. And then my responsibility from there is once I've received confirmation that Dr. House has received it, and that the definition of that process is very flexible. It can go up to you in your practice how you're going to define how you're going to receive confirmation. But once you've sent the document and you've received confirmation, you can check this box indicating that the consulting provider has received the file, and that is what triggers the numerator. It's those two actions together that will trigger the numerator. So again, the denominator is any outbound referral that you initiate and document here in the referrals component during your promoting interoperability performance period. The numerator is then going to be the number of those referrals that involved an electronic summary of care document being sent through the send button and then had the confirmation of receipt checkbox checked. So let's head back to the slides and we'll go over the Health Information Exchange Send Quick Facts. Remember, this is nearly identical to the 2018 measure of Health Information Exchange. The one new wrinkle that we identified, though, is that confirmation of receipt by the consultant is required. Now, what is the definition of confirmation of receipt? Well, it turns out that's going to be up to us as clinicians to determine. Medicare's official wording is the referring clinician must have reasonable certainty of receipt by the receiving clinician to count the action toward the measure. So that could mean a phone call by your staff. That could mean, in the case of a direct message, that you receive what's known as the message disposition notification. That's the file that you get back when you send a direct message. If that file was to show that the receiving health information services provider received the transmission, maybe that could be a reasonable certainty in your mind. It's really up to you to determine, but remember that confirmation of receipt being checked is required for the numerator to score properly. Direct messaging enabled exchange is automatically tracked. That's not to say that it's the only way this can be achieved, though. Remember that other methods of secure transmission of the message are okay, but those would require manual tracking. For example, let's say you're a retinal specialist in your community and she has decided to set up a web-based portal. Obviously, she's taken into consideration HIPAA concerns and making sure that it's a secure portal, and she's provided you credentials where she'd like you to upload the file, and then she's going to log in and grab it and incorporate it into her record. That's absolutely fine, but understand that RevolutionEHR's scorecard will not be able to track that type of action, so you would need to keep a manual note about that. And then at the end of the year, you'd incorporate that into the numerator of the score. Now, of significant importance here is the fact that this requires an exchange of electronic information, an electronic form of a transition or summary of care document. A paper-based exchange or a document sent by fax that cannot be electronically incorporated into the recipient's EHR is not going to be scored in your favor. And that's because the electronic document offers certain gains in efficiency, accuracy, and it reduces chance of error, involved in the transcription of information from paper to the EHR. Now, interestingly, on the very last point here, if you happen to be in a group practice and you're referring a patient internally, you can include that referral in the measure. Medicare thinks that if you go through the process of creating electronic transition of care document and you provide that internally, it can still serve as an alert to that other provider that updated information might be available. So that is the send aspect of health information exchange. Let's take a look at the other side of it, the receive side. And as we said before, the expectation here is that when you see a established patient on a referral basis, or you're seeing a patient that you've never seen before, that you will find an electronic summary of care document and take that through an electronic reconciliation process to build that information into the patient record in RevolutionEHR. The point is very similar to what we said a second ago for the consultant. If you're receiving provider validated information, its accuracy is going to be greatly enhanced over what a patient may self-report. And if you're electronically building it into the record, the chances of transcription errors go down greatly. The maximum point value here is 20. There are 2 exclusions available. Number 1 will not be a possibility for RevolutionEHR customers, in my opinion, because we've implemented that ability for you as part of our 2015 edition software. I think this exclusion exists primarily to help those vendors who might not be able to deliver 2015 edition in time for clinicians to be successful. But as we said earlier, you're going to have plenty of time to be successful with this. I think the second exclusion option is probably more realistic in 2019, and that is if you receive less than 100 inbound referrals or new patients, you'd be entitled to an exclusion if you couldn't be successful. Remember that if you do exclude, 20 points get shifted to the first measure of health information exchange. So let's take a look at the workflow involved in this in RevolutionEHR. To do that, I'm going to jump to a different patient, and you'll see here I'm on the reason for visit screen. Remember, we said that the denominator consists of inbound referrals involving established patients or encounters with patients we've never seen before. Now, patients that we've never seen before, otherwise known as new, are automatically included in the measure. But those established patients that are being referred in need an indication on the reason for visit screen. And that specific indication is this box right here that says transition of care. That is how you let RevolutionEHR know that a transition of care is taking place with an established patient. Okay. From there, there's an expectation that you are going to work to receive that summary of care document and incorporate it into the patient record. Now, in the cases where you have not received a summary of care document, and despite your best efforts to get one, the other provider will not send you one or does not have the capability of sending you one. An example there would be a provider who is using paper records. They have no means of providing you an electronic transition of care document. There is a specific way on this screen to remove the patient from consideration. And you'll see this field here labeled ETOC document. That stands for electronic transition of care document. And you'll see that there are two options in here. One of those options says requested but unavailable. In those instances where you just cannot successfully receive that summary of care document from some source, this indication here, requested but unavailable, will remove the patient from consideration. Okay, so again, if we're looking at what's controlling the denominator here, it's when you see an established patient and you indicate transition of care taking place, and then any encounter with a new patient, okay, those are your triggering events of the denominator, and then that particular encounter can be removed from the denominator in instances when you are incapable of receiving a summary of care document despite your best efforts. And to do that, you indicate requested but unavailable. Now, to see the numerator scoring actions, I need to take you back to the screen that you arrive at when you first log in. In this example, we can see that I've just logged into RevolutionEHR, and I can see I have the schedule component, the messages module, and the task module sitting here. And within the messages module, I'll see that I have a message waiting for me. Now, the address there might look a little bit funny, and that is because that is a direct message that has been delivered from another healthcare provider or institution. And because I have a direct address issued by RevolutionEHR, these two systems can communicate with one another. So when I open up that message, it'll look a whole lot like any other sort of message that you receive, whether that's a RevolutionEHR-based message or, say, a standard email outside of RevolutionEHR where you have a from address, a to address, a date and time. Typically, there'd be a body of the message as well where the other provider or sending institution would be putting in there some details about the referral or the communication that's taking place. But in this case, they didn't. But what we have at the bottom is just an attachment section. So this message entirely consists of just this attachment. To the right of the attachment, you're going to see a little icon there, and that icon has probably slipped your awareness at times, but it allows you to save any type of attachment to a patient's record within RevolutionEHR. So in this case, I want to save this file to a specific patient. I know that patient's name is Catherine Madison. So I'm going to search for her in the system. I will select her name, and then I can put a really quick note about what this file pertains to if I'd like. From there, when I indicate save, that information is then routed to Catherine Madison's record. And if we head to her record, specifically the documents, images component, and even more specifically the transferred messages files, we'll see that file sitting there waiting for us. Okay. Now, if I select that file, we know that this sort of side window opens up over here to the right, and we can see all this information up at the top. But we may not have ever looked down here at the bottom where there are options including update, download, incorporate, and close. And what's really important to this clinical information reconciliation process is the idea of incorporate. When I have selected a file and I select incorporate, RevolutionEHR begins to process the information within that file. And what it's doing here is taking the electronic information within that file and converting it into a format that is easy for us to interpret and read as human beings. So when that first step is complete, what you'll see is we have the option of viewing the document in a readable format to us, again, as human beings, or we can continue the process. And what's going to happen through this continue button is I will get a side-by-side comparison of the information that is in the patient record to that of the information in the inbound file. Okay, over here on the left, we can see the incoming document. Saying that differently, that's the information from the medical record of the primary care provider or the provider who's sending information to me. And then my record for this patient in RevolutionEHR, which this is a brand new patient that we're seeing, so we'd expect this section to be blank in each of these three sliders that we'll be looking at. And if we get some initial orientation to this window, we'll see that there's a section for diagnoses, a section for medication prescriptions, and a section for drug allergies. And I have the ability in each of those to start building my record based on this information from the other provider. So in this case, if we're looking at diagnoses, I am now in a position to start making decisions about what I think is most applicable to my management of the patient or those things that could most potentially influence the eye or my care of the eyes. So in this case, looking across this list, I may see fever, overweight, and chronic rejection of renal transplant as things that may not be pertinent to my management of the patient. So I could highlight that diagnosis, indicate remove, and I'm just going to leave hypothyroidism and essential hypertension here for now. When I then select consolidate, both sides of this view will be merged into one master diagnosis list for the patient. I then can move on to medication prescriptions. And in this case, again, I don't have any information in the patient record, so I will probably just consolidate to build these provider validated entries into my record. And then do the same for drug allergies. I can see that the patient's allergic to penicillin G and ampicillin. I don't have anything in my record. I would like there to be record of that for me. So when I select continue and then confirm to build that information into the patient record, the system then places that information into the appropriate sections of the patient record. So in this example, if I head back to the patient record, specifically we'll go to the medication list for the patient. Remember, we just consolidated some information from that record. We'll see now that the medication list contains those medications. If I then go to the allergy section, we'll see those allergies that we added. And then as far as the diagnosis history, we'll see severe hypothyroidism and essential hypertension. I hope that gives you a little bit of a feel how this process may be of benefit to you, not only from an information reliability standpoint, but also from one of clinical efficiency. I think we've all had those patients that have a list of 10 to 15 different medications, and getting those things into the patient medical record can be certainly time consuming. Here you're able to do that in a much more reliable fashion through a couple actions of the mouse. So let's head back to the slides. And we'll look at some of the summary points here for the receive and incorporate side of the measure. Number one, remember that it requires an electronic file to be received. Again, paper-based documents are no good because the measure is really seeking to push us through this electronic reconciliation process, and that's only possible when you receive an electronically formatted file. And again, it requires electronic processing or reconciliation of that file. As we highlighted, when you've tried to obtain an electronic document but it's unavailable, the encounter can be removed from the measure through the ETOC document dropdown and indicating requested but unavailable. As we said, that could be, example of that could be a provider who is on paper records is sending you a patient. That provider doesn't have the capability of creating an electronic transition of care document, so now CMS doesn't believe that you should be held responsible for that. This is how you'd remove the patient from consideration. Finally, this process of receiving the file, incorporating it into your record, and then reconciling it are not required to be done at the time of the exam, or certainly not done prior to you signing the encounter. It makes perfect sense that there are going to be times when your receipt of that document could come before you see the patient, or it could come weeks after you've seen the patient. Know that you do not need to complete the process by the time the patient is out of the office. Actions that you take before or after the encounter will still count. They just need to be completed at some point during the calendar year. provider to patient exchange is up. This is the one that is analogous to provide patient access from 2018. Remember, we said that there were two requirements here. One involves what's known as an application programming interface, and the other, which is the one that I'd really like you to pay attention to, is that for at least one patient that you see during your performance period, that patient needs to have timely access to their clinical information. And what timely access to their clinical information means is that they have a username and password for RevolutionEHR set up, and that you've signed their encounter within 4 business days. Why does that provide them, or how does that provide them timely access? Because summaries of each of the visits that you provide to a patient are available to them through RevolutionEHR, and it's your signature that makes that information available. So if a patient wanted to recap with their family what took place during their exam today, when they got home later in the day, they could head to their PHR, and as a family, they could view that clinical document together and make certain decisions based on the doctor's assessment and plan within that visit. Now, it's worth up to 40 points, depending on your actual performance, and there's not an exclusion available. Again, that's reinforcing how important Medicare thinks this to be in terms of engaging or promoting and getting patients engaged in their care. And the workflow involved is really very simple. If we head back to Catherine Madison here, if you're outside of an encounter, the demographics component of the patient record is where you'll find the section to establish these credentials. And remember that you have different sliders on the demographics component. The very, very bottom one you'll see is named login information. Down in the lower right, there's an edit button to select. You can then check allow login, and you'll see there's opportunity to enter username and temporary password for the patient. You can use anything that you'd like here, but it needs to be unique across the entire RevolutionEHR patient database. So if I enter some information here just to simulate the process, you'll see here that I have to check the username. It tells me that that email address is unique across all RevolutionEHR patients, and then I can generate a random password that I can then pass on to the patient. When the patient gets home and tries to log in for the first time, they will be prompted to reset their password. But the way that I make this official is I head down to the update button, and those login credentials are then established for the patient. Now, one way that I can know that a patient has PHR credentials is right here in the header. Once I have assigned those to a patient, I will see PHR yes for that patient. Another way to know would be that if I am within an encounter for that patient, I can hover over their name in the patient header bar, and I'll also see PHR login yes. There's other places to note this as well. For example, within the schedule, you'll be able to see if a patient has PHR credentials. But again, the goal is to make sure that the vast majority of your patients are receiving these, because that's what's going to put them in position to access their information if desired. So there's really two aspects to measure success. As I said, you really only need to worry about one of those, making sure that patients have RevolutionEHR credentials through the process that we just outlined. Importantly, as part of that, you need to be successful across all patient encounters during the performance period. What that means is it's very important that you have a process defined before you start your promoting interoperability period, because if a patient comes through early in the period and they are not given credentials, and then they come through subsequent times where they are successfully provided the credentials and the encounter signed within 4 days, the patient still will not count in your favor because they had a single unsuccessful visit during the period. Okay, and I apologize if I made it sound there like you need to establish credentials at each visit. That is not the case. Once you've established a username and password for a patient, then those are set forever. Then it becomes simply a matter of signing your encounters in timely fashion. Again, regarding the API side of this, or the application programming interface, that is something that RevolutionEHR has built. It is something that will be available to external developers to use. You do not need to do anything here with respect to provide patient electronic access to their information to satisfy the measure. It's what RevolutionEHR has done and provided for you will satisfy what's required as far as the API goes. Focus your attention on putting a process and procedures in place in the practice to make sure the bulk of your patients are receiving credentials to access RevolutionEHR. The last objective for discussion here is public health clinical data exchange. And as we said before, this is the one that involves the 5 different types of registries, with the expectation being that we actively engage with at least 2. If we can do that, we would achieve 10 points. Alternately, if we can engage with 1 and claim an exclusion for the second, that we'd also be entitled to 10 points. But if we felt that none of these things applied to us, there are exclusions available. And if we excluded from both of the 2 expectations of us, then the 10 points would be shifted back to the electronic access measure that we just described. Now, I think it's important that we define what active engagement is. If we're expected to actively engage, it helps to know what active engagement is. And really what it is, it's an indication that the provider is moving towards submitting live patient data to those environments. And there's 3 different ways that you can do that. One is to have completed registration no later than 60 days after the start of the performance period. Number 2 is be in the process of testing or validating the data that's being submitted. And number 3, actively submitting patient data. Steps 2 and 3 are ones that are actually declared by the registry that you engage with. Number 1, though, is probably the most clear-cut way to do this. Simply be registered no later than 60 days after the start of your Promoting Interoperability performance period. So if you go over some miscellaneous points here in conclusion, remember that the Promoting Interoperability performance period in 2019 is 90 consecutive days of success. It's going to look like that in 2020 as well. Keep in mind that both Promoting Interoperability and improvement activities are going to have 90-day performance periods, but that doesn't mean you need to use the same performance period for each. You could use the 3rd quarter of the year for Promoting Interoperability and the 4th quarter for improvement activities if you'd like. Remember, we said that the security risk analysis must be completed by December 31st, 2019, even if it is outside of your performance period. That is absolutely okay. You must report a numerator of at least 1 for the numerical measures, or yes for in the case of the public health and clinical data exchange measures, or qualify for an exclusion from the measure. Remember that you cannot start your Promoting Interoperability performance period until the 2015 edition of RevolutionEHR is released, and that is going to be called, again, version 7. Again, the plan is to release that in February of this year to put you in position for plenty of time for success. Your data for this year must be reported no later than March 31st of 2020. There's lots of different ways to do that. And you can report as a group or individual. We covered this in the Things You Need to Know webinar that I mentioned earlier. If you report as an individual, obviously you're evaluated on your own merits, but if you happen to be in a practice of more than one clinician and you choose to report as a group, then the performance data of everyone in the group gets added together and submitted and analyzed that way. RevolutionEHR, of course, will offer you a scorecard to help you track your performance. You'll end up seeing that named MIPS PI Stage 3. That Stage 3 terminology typically isn't used or heard too much anymore, but I think it's still going to allow us to differentiate between the various scorecards and point you right to the scorecard that you need. The MIPS Resource Center on Insight discusses the Promoting Interoperability category, these objectives and how they are accomplished. There's even quick videos on there pertaining to the various measures, so feel free to use that resource. Additionally, if you have questions, the Quest for Excellence community on Facebook allows RevolutionEHR customers to talk about these topics. Perhaps you have questions about how someone implemented a procedure to provide their patients with access to RevolutionEHR. I'm sure there's plenty of people in that forum would be able and willing to share with you how they did that in their practice. For those who don't want to go this alone, RevAspire could be your partner and guide you in participation. The RevAspire team does a number of different things for you, ranging from submitting your data to analyzing your data throughout the year and helping you stay on track and achieve an optimal score, because obviously if it's that score that's going to control your reimbursements, you want to make sure that it's optimal. And then obviously preparing your response in the case of an audit. More information about RevAspire is available through that link that's on the screen here. And finally, questions at any time are absolutely welcome. Feel free to submit those through the application. I think I mentioned this earlier about Ask About MU and MIPS. You can find that in the Help menu in RevolutionEHR. Or if you happen to be outside of RevolutionEHR, quality reporting at rev360.com is a really good way to get in touch with us as well. I want to thank you for your attention. I hope this discussion helps set the stage for future discussion about how to be successful in 2019. If you have questions at any time that you'd like to direct specifically to me, feel free to use the email address on this screen. Until then, best wishes for continued success.